Over to you.
Good evening, everyone. Welcome to our session where I'm the moderator. My name is Devery Stewart, and I'm located in the beautiful island of Jamaica, where it's now evening time. So I'll say good morning, good afternoon, good evening, good night to everyone who is on the session, joining us from everywhere across the world. The Caribbean Regional Midwives Association is a non-governmental organization, and it's a regional midwifery association. We are committed to educate, support, strengthen regional midwifery association. As such, we have been conducting a series of webinars on topics relevant to the care and management given by midwives in the childbearing population. The purpose of this webinar is to sensitize midwives and support clients who have been exposed to gender-based violence. The objectives of this webinar are to define gender-based violence, the causes, manifestations for pregnant clients, the role of the midwife in the care of clients exposed to gender-based violence, and to discuss the role of the midwife in managing clients with gender-based violence. And as such, we have a panel of speakers who are very knowledgeable on the subject, who you will hear of later on and will meet. Before we start, we'll open with a prayer. Lord, we thank you. We thank you for bringing us here this evening on a topic that some of us may find sensitive, but Lord, we ask you to open our minds, our hearts, our understanding for us to gain knowledge and use wisdom while dealing with such topic. We thank you. We thank you for the empowerment of our speakers tonight. Lord, we thank you for those with questions. And we thank you, Lord, that this question will be answered and it will be useful to us in our practices. In Jesus' name I pray, amen. Now over to you, Shirley, who is the president, Dr. Shirley Curtis, who is the president of the CRMA, to bring welcome.
Good evening, good morning, good day, everyone, depending on where we are from. We welcome you. I want to say Happy New Year. As far as our webinars are concerned, I know this is the last, almost the last day of January, so we can still say Happy New Year and welcome to our first webinar for 2024. The Caribbean Regional Midwives Association, we really look forward to presenting these webinars to the diaspora of the Caribbean and beyond. And we hope that the information that you gather at this webinar, as Devery said, it's a sensitive topic to start the year. But you know, we are moving into, we're coming out of Christmas and now moving into Valentine. So this is the time of the year when these type of topics needs to be addressed. So we hope that as our presenters give you the various perspectives on this topic, that you would take that information and apply it to your practices. And we hope that you don't have to, but the reality is we know that at some point you would have to, whether it's in the management or the preventative stage. But we want you to take the information and use it in your practice to better the care of our women and their families. So thank you once again, all 259 of you that are on at this time. And we would wish for you to place in the chat which country you're from so that we can acknowledge you at the end of the presentations. Thank you once again, and do enjoy the presentation. Back over to you, Devery.
I'm here. Thank you so much, Dr. Curtis, for that. As we enter our presentations, what I'd like to bring to the forefront is that according to the UNFPA, one of the most prevalent human rights violations in the world. It's gender-based violence. And as such, we know it has no social, economic, or national boundaries. It undermines health, dignity, security, and the autonomy of survivors. And it is shrouded, however, in a culture of silence, supported by beliefs and values that sustains, justifies, dismisses it as an ordinary component of a male-female relationship. And as such, I'm happy that we are here tonight to discuss and expound on this topic. With us tonight, our first speaker is Dr. Monique Lynch. A little about Dr. Lynch. Dr. Monique Lynch can be described as being dedicated, results-driven, open-minded, and a creative professional who takes great pride in achieving any set goals in life. She's a 32-year-old Christian woman, a diplomat, author, entrepreneur, youth ambassador, mental health professional and advocate, a program coordinator of the PAHO Wu Collaborative Center for the Development of Nursing and Midwifery Education in the Caribbean at UWI Mona. As a leader, Monique has represented Jamaica locally, regionally, and internationally, where she serves in many international organizations as a youth leader and a youth ambassador. As a professional, she has more than 8 years of experience in areas of quantitative research, community development, youth development, diplomacy, leadership, gender equality, education, peace, mental health, preventative and intervention strategies, literacy promotion and advocacy, fundraising, of course, and project management. Colleagues, I could go on and on about Dr. Monique Lynch and her achievements, but I think that one day we could have her to tell her all of her experiences because her bio will span many pages. Without further ado, Dr. Monique Lynch, it's over to you.
Thank you, Devry, for such a wonderful introduction. Observing our protocols, good evening, ladies and gentlemen. I am truly delighted to be here today to talk about such an important and pressing issue, gender-based violence. Now, GBV is a pervasive problem that affects individuals of all genders, but women and girls are disproportionately impacted. By shedding light on this issue, we can work towards creating a safer and more equitable society for everyone. Now, throughout this oral presentation, we will explore the definition of GBV, its various types, the underlying causes, its manifestations, some statistics, and the impacts it has on individuals and communities. Now, what is gender-based violence? Now, GBV refers to any harmful act that is directed at an individual based on their gender. Now, it encompasses a wide range of behaviors and actions that cause physical, sexual, emotional, or economic harm. It is important to note that while women and girls are the primary victims, gender-based violence also affects men and boys. However, due to the prevailing gender norms and the power imbalances, women and girls are more vulnerable to such violence. Now, what are the types of GBV? Now, some of the most common types include 1, physical violence. This includes acts such as hitting, punching, slapping, and other forms of physical harm. 2, sexual violence. This involves any non-consensual sexual act, including rape, sexual assault, sexual harassment, and forced prostitution. 3, emotional and psychological abuse. This includes behaviors aimed at undermining an individual's self-esteem, such as verbal insults, threats, intimidation, and controlling behaviors. 4, economic abuse. This refers to the control or exploitation of an individual's financial resources, limiting their economic independence and trapping them in abusive relationships. 5, online harassment and cyberbullying. Now, with the rise of technology, GBV has extended to the digital realm, where individuals may face or may experience harassment, stalking, or threats online. Now, what are the causes of gender-based violence? Now, GBV is rooted in various underlying causes. Understanding these causes is crucial for addressing the issue effectively. Now, some of the key causes include 1, gender inequality. Now, societies that prioritize male dominance and perpetuate gender stereotypes contribute to the normalization of violence against women and girls. 2, social norms and cultural practices. Now, harmful traditional practices such as child marriage, female genital mutilation, honor killings perpetuate GBV. 3, the lack of education and awareness. Limited access to education and awareness about gender inequality and human rights can perpetuate harmful behaviors and attitudes. Number 4, poverty. Economic inequalities can lead to power imbalances within relationships, making individuals more vulnerable to violence. And we find this happening a lot in our Caribbean setting, where the man mainly controls the finances and hence has the power, and women are more dependent. Number 5, substance misuse and mental health issues. Now, substance misuse and mental health problems can contribute to violent behavior and worsen existing power dynamics. Now, what are the manifestations of GBV? 1, intimate partner violence. This includes violence within relationships such as physical, sexual, or emotional abuse perpetuated by a current or former partner. Pregnant women may experience violence from their intimate partners, which can pose serious risk to their health and well-being, both for the mother and the unborn child. 2, sexual assault and rape. Non-consensual sexual acts, including rape, sexual assault, and marital rape, are severe forms of gender-based violence.
Did we lose Monique?
Are you hearing me?
Yes, we can hear you now. Go ahead.
Okay. So the manifestations of gender-based violence includes 1, intimate partner violence. This includes violence within relationships, such as physical, sexual, or emotional abuse perpetuated by a current or former partner. Now, pregnant women may experience violence from their intimate partners, which can pose serious risks to health and the well-being of both the mother and the unborn child. 2, reproductive coercion. Some pregnant women may face reproductive coercion, where their partners or family members exert control over their reproductive choices. This can involve pressuring them to continue or terminate a pregnancy against their will, or denying them access to prenatal care. Also, obstetric violence. This includes disrespectful, abusive, or degrading treatment to women during childbirth. This can be physical or verbal abuse, neglect, or denial of medical care. Pregnant women who experience this form of violence may suffer physical and emotional trauma, which can have long-lasting effects on their mental health, their willingness to seek future health care. Now, what are some of the statistics? And the prevalence and reporting of such incidents can vary across countries and regions. And even though most of these manifestations are not popular in every Caribbean country, domestic violence is a common form of GBV in the Caribbean. According to a study by UN Women, it is estimated that 1 in 3 women in the Caribbean has experienced intimate partner violence in their lifetime. Sexual violence, including rape and sexual assault, is also a significant issue in the Caribbean. Data from the Caribbean Development Bank suggests that rates of sexual violence against women are higher in the Caribbean compared to global averages. Child abuse, including physical, sexual, and emotional abuse, is another form of gender-based violence prevalent in the Caribbean. UNICEF reports that child abuse rates in the Caribbean are higher than the global average. Underreporting. It is important to note that GBV is often underreported due to factors such as fear, stigma, cultural norms, and inadequate support systems. This means that the actual prevalence of gender-based violence in the Caribbean may be higher than the reported statistics. Now, what are the impacts of gender-based violence? Some of the key consequences include: 1, physical injuries and health problems. Victims may suffer from physical injuries, chronic pain, STIs, and other health issues. 2, emotional trauma and mental disorders. GBV can lead to anxiety, depression, post-traumatic stress disorder, and other mental disorders. 3, social isolation and stigma. Survivors often face social isolation as well as stigma and blame from their communities, which can further worsen their trauma. 4, economic hardships and financial dependency. GBV can limit survivors' economic opportunities, trapping them in cycles of poverty and financial dependence on their abusers. Number 5, intergenerational cycle of violence. Children who witness or experience GBV are at a higher risk of perpetuating or becoming victims of violence themselves, hence perpetuating the cycle. 6, the impact on maternal health. GBV during pregnancy can have detrimental effects on the health of the mother and the developing fetus. It can increase the risk of complications such as premature birth, low birth weight, maternal mortality. It can also lead to stress, anxiety, depression, and other mental health issues for the pregnant woman. And 7, barriers to seeking help. Pregnant women facing gender-based violence may face additional barriers to seeking help and support. The fear of retaliation, financial dependence on the abuser, lack of awareness about the available resources, and societal stigma can all contribute to their reluctance to report the violence or seek assistance. Now, what are some of the strategies for prevention and intervention? 1, education and awareness campaigns. 2, legal reforms and enforcement. 3, support services for survivors. 4, engaging men and boys as allies. 5, empowering women and promoting gender equality. Now, some of the global initiatives and organizations who are working tirelessly to combat GBV, and here are a few notable examples. 1, we have the United Nations SDG, where Goal 5 aims to achieve gender equality and empower all women and girls, including addressing gender-based violence. 2, the UN Women's He for She campaign. This initiative engages men and boys as advocates for gender equality and encourages them to take action against GBV. 3, we have the World Health Organization Respect Framework. Now, this framework provides guidance on preventing violence against women, emphasizing the importance of addressing root causes and promoting respectful relationships. Now, it is our collective responsibility to take action against GBV, and here are some of the ways we can make a difference. 1, we can educate ourselves and others about the issue. We can support organizations working to end GBV. We can advocate for policy changes and legal reforms, and we can promote gender equality in our personal and professional lives. In conclusion, gender-based violence is a complex issue that requires our attention and our action. By understanding its causes and manifestations, we can work towards creating a society where everyone feels safe, respected, and equal. Let us join forces to end GBV and build a brighter future for all. Thank you.
Thank you so much, Dr. Lynch. And that's why we're here this evening, joining forces together to bring an end to gender-based violence and to, as you say, look at the agenda, the Vision 2030, the Sustainable Development Goals of bringing to the forefront to bring an end to gender-based violence. I'm sure my colleagues and the others on the platform will have a myriad of questions for you. So I thank you for that little time you presented and hoping that you'll stay on for the question and answer session later. Our next presenter this afternoon is no other than Mr. Karen Harris. He's a sergeant of police and is a member of the Jamaica Constabulary Force for the past 16 years. He's presently one of 3 center managers for the Area 4 Domestic Violence Center. He is trained to respond to dealing with domestic violence and counseling. He has been a part of the Jamaica Constabulary Force Domestic Violence Intervention Unit for the past 5 years. On the platform, please help me to welcome Sergeant Harris. Mr. Harris, it's now your turn.
Okay, Ms. Stewart, can you just give me 2 minutes? I'm trying to get my colleague for me. So.
That's fine. We will give you 2 minutes indeed.
Okay.
Dr. Curtis, do you have any words to share?
Okay, maybe persons might want to put questions in the chat that they might have for Mrs. Lynch while we wait for Sergeant Harris. Are there any questions? Bernadette, did you see any questions so far in the chat for Mrs. Lynch? Or maybe somebody want to put some there now or raise their hands and ask them in person? Any questions?
Hi, good night. I have not noticed any questions in the chat. If there are any pressing questions, probably persons at this time can feel free to raise their hand or, as you said, put the questions in the chat. And we'll seek to address them as we wait for Sergeant Harris.
As we wait too, I think it's a good time to reflect on what Dr. Monique Lynch had presented. And to see, you know, if when we're delivering care to women and their families, how well do we look at the family in total to really understand what is happening? And how can we use this information to enhance what we do? I saw a question in the chat.
Okay, yes, we do. We have one question to Dr. Lynch, and the question is, how do you deal with gender-based violence in pregnant women? Dr. Lynch? How
Now,
do you
one of our presenters will be presenting
Will-
on that.
Ah.
But Mrs. Lynch, I don't know if Mrs. Lynch
I
want to
think
give
that's
her
a question for
perspective.
Dr. Peter.
Yes. Yes. So that's why we would normally leave the questions for the end, because one person is presenting on one perspective
Yeah.
and others will be presenting on another perspective. So Dr. Pitter will be presenting on the midwife's perspective. Dr. Lynch says she's staying in her lane. She is not coming over there.
Yes, so the
Definitely.
question will be addressed during Dr. Peter's presentation. Very
Definitely.
well.
I hope so.
Certainly, certainly. Is Sergeant Harris ready? No.
The thing is that Sergeant Harris is not feeling well, so he was trying to get one of his colleagues to do the presentation.
I don't know, Dr. Peter, if while Sergeant Harris is doing that, if you look at the midwife's role,
Yes, we can probably do that.
and then we look at his perspective on our roles afterwards.
Mhm.
Yes?
Yes, we can
Okay.
do that.
Well, allow me to introduce Dr. Peter, who is no stranger to us here in Jamaica and most of the Caribbean by now. And now we're exposing her to the rest of the world if you haven't met her before. Dr. Cynthia Peter, in 2001, Cynthia Pearl Peter became intrigued by the lack of data and interventions on household and institutional silence on gender-based violence during pregnancy. It was an observation that influenced her PhD on the challenges and opportunities to reduce gender-based violence during pregnancy. I quote, "I believe that both the pregnant woman and her midwife should be equipped to raise and care for the next generation free from violence. However, I find it remarkable that the approach to gender-based violence on maternity care is undefined and considered loose in Jamaica." End quote. That's from Dr. Peter. Dr. Peter is a Jamaican nurse midwife and a gender specialist with a PhD in Gender and Development Studies from the University of the West Indies. She lectures and coordinates the Master of Science Nursing program at the UWI School of Nursing Mona campus. She is a trainer, researcher, and publisher on women's health, gender-based violence, respectful maternity care, fatherhood, as well as competency-based education for midwives. Her educational background includes having a Master's of Science in Nursing Education, and an advanced certificate in nursing administration from University of the West Indies. She is a graduate registered nurse and registered midwife from the University Hospital of the West Indies. Her PhD work has corrected the gaps in preparing nurses and midwives to be more responsive to women experiencing gender-based violence during pregnancy. She has successfully led the UWI Faculty of Medical Sciences and UNFPA, the European Union Spotlight Initiative Jamaica, in strengthening integrating violence against women and girls, the VWAG project, in nursing and medical programs at the University of the West Indies. She was recently added to the WHO HQ roster as a trainer and researcher to assist with the mitigation of VWAG around the world. She is a trained sexual and reproductive health researcher and a member recipient of the Geneva Foundation for Medical Education and Research, WHO HQ Switzerland. She is a 2018 awardee of the Erasmus and Staff Mobility Fund from Birmingham City University, UK. A former writer of the National Council Licensure Exam NCLEX. She is a reviewer for the Virtual International Day of the Midwife, International Confederation of Midwives, Sigma Theta Tau Nursing International Conferences, and the International Journal of Childbirth. She is an editor for the Iranian-based International Journal of Community Nursing and Midwifery. Dr. Pitta is a former board member of the Nursing Council of Jamaica and the Caribbean Regional Midwives Association. She coordinates the Young Midwifery Leadership Program in the English-speaking Caribbean, an International Confederation of Midwives initiative, and is a member of the Omega Kappa Honor Society of Nurses. She is the midwifery representative for PAHO WHO Collaborating Center for Nursing and Midwifery in the Caribbean at the University of the West Indies, Mona campus. She's a Kiwanian, a board member of the Institute of Gender Development Studies, UWI Mona. She has volunteered at the Women's Incorporation and serves as a director at the Jamaica Family Planning Association. Dr. Pitta is currently working on a book project in which she has galvanized midwives from the region to unite in writing the first midwifery textbook for the Caribbean community. She is on a mission to use the human rights framework to inspire nursing and midwifery students to safeguard, respect, and always promote people's health rights in all spaces. Of course, with all that background, Dr. Pitta has written book chapters, and she has also published in numerous journal articles that if you should go online, you would find, or you could contact our association to get these articles, or Dr. Pitta herself. Ladies and gentlemen, without further ado, help me to welcome Dr. Cynthia Pitta.
All right, good evening, everyone. Are you seeing my screen?
Yes, we are.
All right,
Yes,
thank you.
Dr. P.
Thank you. All right, so I want to thank Deborah, my colleague, for her introduction, and also for Dr. Monique Lynch, who has, set the pace for tonight's presentation. Well done. Dr. Monique, that's a publication, you hear? All right, so I kind of shift what I was asked to do about the role of the midwife to a more, it will come out, but at the same time, while we are caring for our patients, I realize that we also need to care for ourselves. All right, so Dr. Monique has set the pace, and I will go forward. 1 in 3, that's a big issue. We are having a crisis. And, looking at the numbers, 398, 1/3 of us could be exposed to gender-based violence. That's the reality. And if we were in a room with at least 100 persons with COVID-19, none of us would want to stay in there. It would be a crisis. So I want us to look at gender-based violence as a crisis. I became aware of this situation when I was my first year as a staff nurse, being exposed to patients on the ward. At that time, nobody ever talked about it. You just know that a patient came in with contusion based on a known assailant hitting the person with a hammer in the head. And of course, I end up talking with the perpetrator, not realizing it was the perpetrator. It's weeks after, then I was talking with a friend outside of nursing, and he was giving me the scenario that he went to the hospital and he was talking to a nurse, and the nurse talking to him, telling him, oh, the person who did this to this person is such an awful person. I wasn't trained then. So I know, so I was able to say, it was me. And so that was in general nursing. in midwifery as a pupil, again, I come in contact with persons, and we find that many times some of these patients who are exposed to gender-based violence or intimate partner violence are the ones that are sometimes very difficult, are the ones that are quiet. And you know, sometimes us as nurses and midwives, when we have difficult patients, you know, we don't want the confrontation and we try to avoid, all right? So it was during her quiet time, a particular patient in her quiet time, that she revealed to me that she was being abused. No, I didn't do anything about it because I do not know what to do. There was no modeling, there's no policy of what to do. You just, you know, reassure, and that's all. And I'm sure many of you here can identify with me that in your institution, there are no policies, there are no guidelines, that there's no clear pathway as to what to do. All right, so this picture, this picture that I have here is a permission that I got from these 3 persons while I was doing my PhD. So Dr. Monique Lynch had already gone through some definition of terms. I will do an overview. I will look at a culture change. What do we need to do to make a change? You know, because we can't be doing the same thing. We are going to get the same result. We'll be looking at the midwifery model, just an overview. Look at the women-centered care approach, and of course, psychological first aid and lives. That's what I want. If you don't get anything, I want you to get psychological first aid, because when you leave, this is teaching you, helping you to how do you respond to someone in a crisis. Probably if I should ask any one of you here today, did you experience a crisis? And you can be able to say, yes, today when I went to work, this is what happened. My baby woke up this morning, was having a headache or something. You know, we experience crisis every day. So it's psychological first aid is applicable in all areas of our lives. And I want to touch on the fact that midwives are also survivors of gender-based violence. Every time we talk about gender-based violence, we speak to the patient. And that's one of the advantage for me as a nurse and as a gender specialist. Because as a nurse, we are taught, we more look at the pathological and the clinical aspect. And we are taught to talk about the patient. We talk about the patient in the third person, as if it can't happen to us. And realizing that because most of us are women, we are also subjected to. So as a gender specialist, whenever I come to learn, and I want you to learn also that when we talk about certain issues or any issues at all, it can affect us also. So we can talk about we, and it's okay to talk about we, to include us, because we are also reminding ourselves, we are grounding ourselves, we are becoming self-aware, using emotional intelligence to say, you know, this can happen to me. This can happen to somebody that I know. It's not like, oh, diabetes, them have diabetes, them have HIV, I don't have it. You know, it can affect any one of us based on our practices. All right, so let's move on. Monique spoke about gender-based violence. Gender-based violence is one of the terms that you will find that, which one use it? Not WHO. WHO would use gender-based violence, and UN will use violence against women and girls. I'm trying to get it right. So gender-based violence, like Monique said, it's that umbrella term that could include female genital mutilation, all of these things that I've also listed here. While violence against women and girls is more specific to the woman based on the gender, all right, woman and girl. And the most pervasive of them all is intimate partner violence and domestic violence. Domestic violence, it depends on how you interpret it, because domestic violence is persons in the household, in our household, things can be happening to. We are very brutal. We see it on the video recently. with our children, some because of, the abuse, the abusee, abuser become the abuser. We are very brutal with our children and how we raise our children. So that is abuse in the household. But specifically what we're talking about is now men violence against women and girls. And, and as midwives, we are also aware that there are changes taking place and not all relationships are heterosexual. We also have some that are homosexual. And within what I find in my reading, that all spheres, all population, it's usually 1 in 3. So regardless if it's homosexual, it's a heterosexual, 1 in 3. We are a violent people, all right? So we move on. So what we are zeroing on is the intimate partner violence. And I can say to the organizer of this webinar that this is just the tip of the iceberg of what we are talking about. Because I would like us to have a webinar on sexual violence. A lot of people are hurting because of this. So while Monique talk about the types of domestic violence, which includes sexual, because from a pregnant perspective, every rape, at least 5% of rapes will end in pregnancy. And as the thoughts come to me, sometimes I will just talk and move away from a slide. So that is why when we as midwives encountering women, we have to center ourselves. Remember, I talk about the psychological first aid. We have to center ourselves. We have to be aware because we were taught certain things. So the woman is pregnant, ask a baby father to donate blood. Not everybody has a baby father. The person could be raped. So I want us to be aware. Somebody mentioned these, she said, a cyber technical abuse, but another one that I reflected on, and I've not seen it written. I think I read it once about spiritual violence. We are in the Caribbean, and we know how a lot of our Caribbean people practice obia. And that in itself, it could come under psychological, that is intimidation. We tie, and I use the word tie, we tie each other. In toxic relationship, we wonder why people cannot walk away from these things. Something for us to explore as a people. So I want to define these two words, a survivor versus a victim. A survivor, when we use the word survivor, we are giving back the person the ability to self-determinate. We're giving the person, empowering the person, versus when we use the victim. Sergeant Harris and his team will tell you that they have to use victim, when it comes to if the person wants to get redress. Because you can't be a survivor if you go to the police. I'm a survivor. You have to say you're a victim. So the judge has to see you as a victim for you to get redress. And I just want to bring out that. Monique also spoke about the various framework that guides violence against women and girls, gender-based violence. We also have now the UN Sustainable Development Goals, and in particular, number 1 that speaks to poverty reduction. When anybody is in a toxic relationship, have you ever seen some persons in toxic relationship and they rent somewhere, they fight, they break up everything in the house, they move again, furniture, mash up, burn them furniture? That's poverty. Examples of those. It also promotes maternal health, which includes sexual and reproductive health and newborn health. And as midwives, we know about that. Number 5 speaks to gender equality and empowerment. And Monique spoke about that. Sometimes when we talk about gender-based violence, there is always somebody in the crowd, and I'm waiting to hear it. What happened to the men? It's okay, ladies. And I know men are here. It's okay for you to be the center of attention for some time. It's okay. It's a way of defense mechanism. It's the same way when we're watching the news and we have to be careful. We hear that somebody was raped, they went on a date, And we feel so good in saying, because she was wearing a short dress. Mechanism, self-defense mechanism again. All right, so the next one is number 16 that speaks to accountable institution, the institution that we are a part of. What can we do in our institution to make a change? The WHO, and I just want us to think about this. This is blocking me. I said defines maternal death as a death of a woman during post-pregnancy of 23 days after the termination, 42 days, sorry. But when a woman dies as a result of gender-based violence, it's not counted as a part of the MMR. As a matter of fact, according to International Classification of Disease, gender-based violence is not classified as a disease, although we know the effects, we know the trend, we know how we can prevent them, but it's still not classified as a disease. All right, so it has legal implication. Sergeant will talk about it. It has social implication. Social implication, a lot of times, gender-based violences reach into the workplace. Many women died at the car park, in the car park, because the person know that the person is going to work and just wait for the person. And other social children having issues and all of that. It's also a human right. But because we are a health person, we are focusing on the public health issue. All right. So our women of reproductive years are usually healthy people, and they will only come into a health institution whenever they have sexual and reproductive issues or when they're pregnant or come for contraceptive. This is a moment. These are moments. Pregnancy could be as a result of gender-based violence, vaginal infection. We have to center ourselves again. We are in the clinic, someone comes and says, nurse, I have to go home. I have to go home now. And we say, you have to wait your turn. It's number 100 you get. The person knows that the spouse gone to work and just using this opportunity to come and grab their contraceptive. So we have to be mindful of those things. Our roles, Dr. Curtis, as always, we are clinicians, we are educators, we are administrator, we are advocate, we are researcher, we are policymaker, and we, people could put in the chat other things that we do, but we're also politicians because we have the power as midwives to influence decisions, influence policy, and I want us to look at that. So in terms of a culture change, we can't just sit down and wait for, we're waiting for authority. Most of our institutions are patriarchal, has a patriarchal structure, right? And patriarchal structure does not mean that a woman is not at the head, because we were all socialized within that framework, all right? So what are the things that are influencing the change? The curriculum, all right? Influenced by, no longer we are certificate, we are BSN group of people, and we have to put in certain things in the curriculum. The evolving changes, new expectation out of COVID. For example, in COVID, we know that the home is the most unsafe place for women before COVID. And think about it, during COVID, a lot of women now were working from home. So they were in a toxic space. As midwives, as healthcare worker, we could have gone to the workplace to talk about gender-based violence, but they were working from home. So things like that, new expectation. What are our patients expecting of us? They're come expecting to see, it is such a topical thing, come expecting that when I come, there must be somebody in the clinic that I can talk to. So there are evolving needs. And of course, influences from the international partners, UNFPA, WHO, are going to, recently in the Caribbean, we had the Spotlight Initiative that, evoked or reminded us, or they supported us in putting things in place. And when I look at it, it's just, we have a framework, a public health framework that we can use. We know that we assess the situation, we investigate, etc., etc. we plan and we implement and we evaluate. It's the same public health framework that we can use to make the difference. When we talk about women-centered care, we're also talking about mainstreaming gender, because there is a need to mainstream gender in our institution. When we mainstream genders, we think about policies, structures putting in place that will affect both men and women, and not just men alone or women alone. So everybody will be addressed. For example, there's a hospital in Kingston that the fathers, because of structural problems, the fathers are not allowed at the bedside when the woman giving birth. These are something that we need to talk about, right? You know, many fathers have to wait until the baby is born, come back during visiting time. What are we doing there with the family? All right, so things like that. And remember, you know, midwives' emphasis is on being with women. So I will happy to share my slide with you if I'm going too fast. So the woman-centered care focuses on women's unique needs, their expression, their aspiration. All right, and of course it has to be collaborative with the midwives and the women. And of course there must be mutual respect and knowledge and experience that looks at the well-being of mother and child. The next one is the midwifery model of care. It's not the NANDA, the North American, it's not that. Pregnancy supposed to be a normal event. So we have to use a midwifery model of care, that personalized care. So it's a midwife-woman relationship, and it personalizes care. It builds and develops trust. So when a woman trusts you, she will share with you, she will open up with you. Dr. Monique Lynch spoke about the 1 in 3 and said that it could be more. It could be more, because it takes up to 35 times in asking a person about it. Are you okay? Before they really open up to you. And in so doing that, we will empower our women. Why the emphasis on women? We are private creatures. We want to be seen as people with no problem. We want to appear that everything is under control, and we want to try to gain some semblance of power. And even when they come in our space and they're quarreling with us, it's us, they're taking it out on, you know, because they want to get a semblance of power. And I could go on and on with this slide, but I'll move on for time's sake. So we have to look out, especially for our older women. You know, they don't know how to navigate these things. Our younger women know, if you notice what those of us on TikTok, they will now come on TikTok and say, people watching a thing. So they have that avenue. Older women not going to do that. So it's a global burden for women, all right? Sometimes we'll hear that women will kill their spouse. That's debatable as to why, but very often when a woman retaliates or she's the abuser, it is less frequent and it's less severe. I'm not saying it's okay, because if you look at the statistics, 80% of the time it's the women who are being abused. So the other 20% are also being abused, and that is a whole lot. All right. And whenever it affects women, it affects everyone else. All right, so I'll move on quickly because I don't want to run out of my time. Why women will not disclose? Sometimes we have to walk in their shoes to really get an understanding. When I walk away from this relationship, who's going to pay the school fee? I remember in my study, and I was talking to a lady, and I said, would you walk away? She said she can't, because where she was living with her family, somebody else took that side of the bed that she was normally sleep on already. So what is she going home back to do? So these are some of the realities that women are facing as to why they are not walk away or not disclosed to us. You know, us Caribbean women, we love our men. We really don't want them to walk away from us, you know. We just want them to change. I know we are nurturers. So we think we can change them. All right. All women are subjected to abuse. The thing is that the poor, the young, the uneducated, they're the ones that we normally hear about. So we can't take anything for granted to say we see this well-to-do woman comes in. I'm not going to ask her because she's not being abused. Why women? This can lead to pregnancy. It can be amplified during pregnancy for many reasons. It can expose women to HIV, cause her to have induced unsafe abortion, more prone to mental health, with the hormones, fear of their lives as well. But it also, amen, provide a window of opportunity and us as midwives to do something about it. And I will move on with this slide. I will be happy to share my slides. Dr. Monique spoke about these things already, power control. Yes, some men, partners, are jealous of the pregnancy, all right, because they know that the woman now is going to have to go to clinic, and it's an opportunity for the woman to get help. Somebody will see the woman. That is why a lot of women, some women will be at home and they never work, and the minute they start to work, somebody else starts to see them. And the reality is, especially us midwives will get the call, why you now come home, but you have to do extra work, extra hours, you're doing sessions, and you hear you have some doctor you have up there waiting, you're going with, things like that. That's the reality, we know that. All right, so, and it comes back to social issues again. Midwives, we are female dominated. It can happen to us, but guess what? We have more education, we have more power. All right, so we have to protect ourselves, and our duty is to protect our women and the next generation. Midwives have always been on the front line. We give repetitive care. So we'll see the woman at least 4 to 8 times during the pregnancy. Many studies show that we are the most confidential, nurses and midwives, most confidential professionals in the world. We have the autonomy to educate women. We don't have to wait on anybody. We feel that midwives feel that they have a role to play. So when you look at the studies over and over saying, we know as midwives, we have a role to play. All right. In the antenatal clinic, we're talking about the public, that it's a public issue, but it can also be hidden if we are not sensitive, if we are not grounded, if we are not self-aware, if we do not have emotional intelligence. So we have to set the pace. I know of some situation where the midwife would put the name of contacts in the bathroom. So when the patient goes into the bathroom, they will see. So it's not on the outside necessarily for them, if the spouse is there. Because sometimes, as midwives, when we are happy when we see a woman with her spouse and say, yes, so he's so supportive, especially if we have a spouse that is not supportive. Oh, he's so supportive, but we'll never know. Could be controlling. All right, so we have to be mindful of that. We have to see women as individual, and we have to use a referral system. Dr. Monique spoke about the effects on women on a whole. This slide is showing, which seems to repeat some of the issues that can affect women. And of course, death can be an outcome both for the woman and for the family. In Jamaica, at least 2 to 3 women per year who are pregnant will be killed. What is my slide saying? So the birthing experience is also affected, because think about it, someone that was raped or being abused. That is why we need Dr. Shirley to come back with sexual violence in labor. And if we don't get permission and we are being disrespectful to the person, open up your legs. Probably that's what the abuser said to the woman when he was raping her. Or over and over, I can't understand, generation after generation of midwives will say, when the woman crying, or if they're doing the VE, Why you're crying? You never know what you do when you get baby. How can we continue saying these things to women? We don't know the woman's story. Okay? So think about a woman who had experienced childhood sexual abuse, or even whether it was or within their framework. So we have to be grounded, because during the birth experience, it could trigger, because the blood, the instrument, and all of that, we'll never know. So we have to be mindful. We have consent from the woman when we are doing investigation, etc., etc. All right, it also affects children, and Dr. Monique spoke about that, so I'll move on from here. But for emphasis, the children, they know that what is happening in the home. They hear. Sometimes the woman trying to protect herself will grab the baby, thinking that if she has the baby, she will stop getting the beating. And very often it does not stop, and the baby ends up getting injured. So we see a baby come in with injured, we can think about, we are not going to say, yes, it's domestic violence, but we have to be aware, okay? Do we screen? Do we have universal screening for gender-based violence? The debate is there. A lot of midwives you talk to, no. You see, if we are not, and that is why the undergrad curriculum is so packed, because over and over we recognize that if we don't put it in the foundation, it's hard to change after when we graduate. I don't have no time. Where you go with this? I know my business, etc. And these are reality for you. You don't have no time. You have no time to sit down with anybody for half an hour, cry. And you want cry too, and all of these things. So WHO does not recommend universal screening for every woman that comes into the health institution. But what the WHO guideline is, use it in antenatal clinic. It's an opportunity, because we're talking about at least 2 lives at risk. So the debate continues, but why they don't say universal screening? Because when you let a woman explain herself and disclose, and then she cry, and you don't have nothing to help her, you don't have no resources, just hush mommy, and she goes home. It does not help, all right? So so that is why we have to change the structure of our institution. WHO target in 2017 was for us to reduce intimate partner violence by 10% in all generations. We know that COVID came, and for many targets, women target, those numbers were erased. But we still have to persist that we are going to be a part of the solution. Prevention is the key. So screening, when we talk about screening, I don't know how many of you in your institution screen, because if you screen, you have to have guidelines. You have to have protocol. You have to have screening tools. All right, so it's not just about talking to the person, but you have to have mechanism. Who do you refer to the person? I know one hospital in Kingston. So we know there are various types of gender-based violence. So if somebody come and say, my husband not giving me any money, the hospital does not necessarily have money to give you. Or my husband is intimidating me. But what they will do for physical and sexual abuse, they will intervene. So these are some of the dynamics that we have to look at in our institutions to sit down, have screening tools, have protocol guidelines, who, when, how do these things. We're supposed to do that. Someone comes in with sexual assault. How many persons are going to be there? Are we going to have the medical student, the student nurse, the people midwives there, looking at the person, asking the person all of these questions? So this is where, when we have structured screening, so this is a tool that can be used for pregnant women. It's very graphic, explain if you can highlight, tick the areas that she presents if she's having physical abuse. And this was psychometric assessed to be, it was validated to be using Jamaica I know of, because our own chair for the Nursing Council validated this, and I'm sure it can be used in other parts of the Caribbean, of the Caribbean community. So the screening mechanism or the screening pathway or pathway of care would also teach what to say and what not to say or what to do. Okay? Do not ask the woman why, because you're going to re-victimize her. So the minute you say why, especially why you don't leave him, you're going to let the woman think that she's weak. Do not talk negative about the survivors, and do not talk directly to the abuser about your suspicion. You don't want to get caught up. You have to be smart, because if a woman come and indulge, disclose, and you said something negative about the abuser, she's going to feel so empowered. So she's going to go home. And I'm not seeing any of your name now. And that is why when I went to clinic, I tell Nurse Curtis, so and so, oh, you don't understand my pattern, sorry. That is why when I went to the clinic, I told Nurse Curtis, and Nurse Curtis said, so and so, so and so. You know who is going to come looking for? Nurse Curtis. Who tell you to tell my woman to leave me? So it's you going to get it. All right. So we need to be sensitive and be self-aware, because she's trying to get back the power. And remember, it's during the time that the woman is trying to leave the relationship, she's more susceptible of being killed. You don't want them to normalize it. I remember I met a lady and she disclosed that she was raped. And I said, how do you feel? She said, you don't know that. I said, go. I said, the man, Jamaican man, them stay. I'm sure the men are here. That's not how you stay, right? We want to help them to secure their important papers, especially if they have to decide that they're going to leave the relationship. And of course, they're through the UN and WHO now, they're domestic violence care center, like what we have in Jamaica, is being popped up now, so you can refer them to these things. All right, so so that is if you have a structured pathway, a thing that if I come on your unit, I can take up to see how to guide me. You will tell me that your institution probably don't have, but what do you do? Because each day you face someone with experiencing a crisis, and how do you do it? How do you know the person is having a crisis? They appear nervous. And I don't even want to go through these slides, because I'm going to show you a video that all of these things will come out. The psychological first aid. This is what they use in after disaster, during and after disaster. The Red Cross, and this mechanism where they utilize, you want to instill hope, you want to provide support and guidance for persons who are in crisis. And the WHO has used this, applied to care of women exposed to gender-based violence. They use 3 L's. Their principles, main 3 principles are look, listen, and link. It benefits, it gives us the opportunity to assess the situation. So think about you yourself. This morning you have a crisis. How did you assess the situation? Was there a pattern? Things like that. So I'm going to move on with this slide. So it helps also when someone is in distress, and it's, like I said, usually immediately, shortly, or long after a crisis. Because a lot of women will suffer PTSD, right? So it could be you, the midwife, having a personal crisis. As a young nurse, when I was asked to reassign to another ward, I'm always having a crisis. So that's a crisis for me. Not to lessen it though. So WHO, instead of using look, listen, and link, they have what you call LIVE, lives, and I'll show you what it says. Lives, I'm not seeing mine here, but it speaks to listen, inquire, validate, enhance safety, and give support. So let me stop sharing this and I will show you a video that you can use for yourself in any crisis. You can share at church, wheresoever. I want to share, sorry. Where is it? This. And I want to share some. I'm having a crisis now.
In this video, I'll be talking about the 3 action principles of psychological first aid: look, listen, and link. The first action principle of look involves a number of different actions. The first one is to gather information about what has happened and is happening. If you're in a situation with many people, you need to find out who needs help. The next action is to explore safety and security risks. If anyone is unsafe, you need to address that first before going on with other PFA actions. After you've made sure that you and a person in distress are safe, next thing to check for are physical injuries. If you encounter someone who has physical injuries, tend to them first before going on with other help. Another action is to assess immediate and practical needs. Find out what the person in distress needs help with right now and here. And last, it's important to recognize what reactions the person is having to assess whether these are what we call common reactions or whether the person is displaying severe reactions.
Is a banana a metabolism booster or a killer? I just heard the truth from this guy and my mind was blown.
This is a metabolism.
Some examples of common reactions to distress include physical reactions, such as shaking, sweating. Some people have stomach problems and feel nauseous. Some people have problems sleeping. Others feel an increased heart rate when they're in distress. Some people have difficulty breathing. And sometimes people feel they have no energy at all. Examples of behavioral symptoms of distress include withdrawal and isolation from other people, crying or screaming. Some people laugh when they're in distress. Others find it difficult to move, especially if they feel shock, while others find it difficult to keep still and may pace and walk around and not want to sit down. Sometimes people overeat or don't eat at all when they're in distress, and some people may show aggressive behavior if they're feeling a lot of anger. Another behavioral sign of distress is increased smoking or alcohol or drug use. Examples of emotional reactions are feeling shock, feeling fear, feeling anger or sadness, feeling anxiety, or not feeling any emotions at all. Some people also experience mood swings. They feel happy one moment and sad the next moment. And last, you may also feel quick irritation. Cognitive symptoms of distress refer to what happens in our mind. So, common cognitive symptoms of distress include poor concentration, feeling confused, having disorganized thoughts, perhaps forgetting things quickly, finding it difficult to make decisions, having dreams or nightmares, or what we call intrusive or involuntary thoughts. And last, there are also sometimes spiritual symptoms of distress. That includes perhaps feeling a sense of emptiness, perhaps feeling discouraged or losing hope, and generally just feeling negative about life. Some people may also doubt their faith, or feel anger at God, or perhaps feel a sense of alienation from other people, or a loss of connection from other people. It's important to remember that common reactions to distress are what we call normal reactions to abnormal events. However, you need to also recognize when someone is having a more severe reaction, because then you may need to make a referral and ensure the person gets more specialized help. Examples of severe reactions include if someone has been unable to sleep for many days and starts to feel confused or disorientated. Another severe reaction is if someone is unable to function normally and care for themselves or their family. So, for example, they stop practicing hygiene or cooking or eating. Another example of a severe reaction is when someone loses control over their behavior and they perhaps become unpredictable or destructive. Another severe reaction is if someone threatens to harm themselves or to harm others. Or if someone starts excessive and out of the ordinary use of drugs or alcohol. If you meet someone who's in distress that has a chronic health condition that needs specialized support, you also need to refer them for immediate help elsewhere, or if they present symptoms of a mental health condition. Now I'm going to tell you a bit about the actions of the action principle listen. So listening is more than hearing. Hearing is what we do with our ears, whereas listening is what we do with our entire body and being when we encounter another person. So listen starts with how you introduce yourself. When you encounter someone in distress, it's calming for them that you introduce yourself in a good way and explain who you are and that you're there to help. It's also important to pay attention to the other person and listen actively. Active listening can be shown in both verbal and non-verbal ways. Verbal ways of showing that you're listening are sometimes repeating what the other person has said and checking for understanding, or saying, or I understand what you're saying. Non-verbal methods of showing that you're listening include facing the other person directly, having an open body posture, nodding when they talk, keeping eye contact. It also involves calming someone. There are many different methods you can use to calm someone in distress. A common one is to guide them through a breathing activity, where you ask them to follow your breath and take a few deep breaths with you so they can feel calm and centered and able to manage their situation. Listening also involves asking good questions. So asking questions for clarification, asking questions about the person's needs and concerns in this immediate moment. In that way, you can help someone to find solutions to their problems. The last action principle of link refers to helping the person in distress access information. When you go into a situation where you know you'll be providing PFA, it's good to anticipate what kinds of reactions you think people may have and come prepared with psychoeducation material. Psychoeducation helps a person understand the reactions they're having and can also give some tips on how they can manage their situation. Link also refers to connecting someone in distress with loved ones and social support. So be prepared to maybe lend someone your telephone so they can call their loved ones. Link also refers to tackling practical problems. Earlier we talked about asking questions about needs and concerns. Link refers to thinking more about how to tackle the different problems and then guiding the person into getting more help elsewhere. So the last part of link refers to accessing services and other help from other people or institutions, and it can be informal help or formal help. It all depends on what the individual person needs. It can sometimes feel difficult to help someone who's in distress. Therefore, it's important for you as a helper to always practice self-care. When you've learned the different action principles, look, listen, and link, you can apply these to yourself also. You can look and recognize your own symptoms of distress. For some people, that means perhaps they start snapping at their family or not coping in the way that they usually do. And when you recognize your own signs and symptoms of distress, it's important that you listen to yourself and start thinking about the action of link. So if you're very stressed and you recognize that you're not handling things the way that you want to, stop, listen to yourself, and think about what you need to manage your situation better. There are also multiple ways that you can practice self-care. One way is to focus on simple and routine tasks if you feel overwhelmed. Another important method is, of course, peer support. Talk to friends or colleagues about how you're feeling. Also, remember to do exercise, rest and sleep well, eat and drink healthy, and avoid overuse of alcohol or substances. Do things that you enjoy and ask for help when you need it. You can learn more about PFA by downloading our guide on PFA from our website, and there are a number of different training materials you can use.
All right, so that's all. Oh, I need to turn. Sorry.
Go ahead, Cynthia.
Oh, my video is still running. Oh God, how do I come out of this?
No, we're not seeing your video.
Oh, I'm lost. Oh, never mind. Zoom. Okay. All right.
But you're trying to get back into the PowerPoint?
Yeah. Are you seeing? I'm lost.
You need to stop share and start again.
Yeah.
You seen anything?
You see in Zoom?
All right, all right.
Yeah.
Okay. Oh, technology. What you see now?
Yeah, you see it now.
Great. Slideshow. Right, let me go down to where I was. So however, I could finish up in next 5 minutes because most of the slide has the things that we discussed in the video. Okay, so this is where we were. Okay, so we'll move from there, and I've been hinting as I went along. Out of my study, I found that having resources is very important for the women. So that's why a lot of times they don't leave the relationship. Where am I? All right, so I have it like this, documentation. We know as practitioners how to document. All right, so I want you to bear in mind these 3 bulletins that I have as I move along. All right, we don't want to implicate ourselves. But mandatory reporting are gunshot wound with serious body injuries, children when they are involved, and person deemed mentally ill. Dr. Lynch give a hint about respectful care, which is very important in gender-based violence as midwives. So there's no way that a woman is being disrespected at home. And when they come into our space, they are not empowered because practitioners, as we are going to be disrespectful to them. One study that I did on respectful care was done at a hospital in Jamaica, and out of it, the woman defined this, one of their indicator for disrespect care was not having their spouse at their bedside. They think that that is very disrespectful. So we can think of various different ways how we as clinical practitioners can be disrespectful. We don't think that we are doing it, but the minute you start here, you say, ma'am, you're going off to another realm. So let us be mindful, let us be tactful. We can't say we are protector of women because we are protecting them from their spouses, but when they come to us in our care, we are disrespectful. All right, so one of the quote that I like from Day Stark, one of my favorite Jamaican nurse. She said that the status of midwives in a country often reflects the status of women and the value placed on them by society. This can mean a whole lot of things, all right? So if in our society, women are being disrespected, most of us here are women, and we need to look into that also. So let us not be a part of the team that is disrespecting women. I hinted already, if you look at the psychological first aid, we can see how we can apply it to ourselves. We know that some of our midwives, our nurses are being abused. Pardon me, because this could be a trigger for you also. All right, I will say to you, get help, get care. All right, use those same psychological and apply it to you. So if a patient is diabetic and you're giving insulin and you become diabetic, you have to take care of insulin. All right, so that's what I will say about that. I have here some contacts that are local here. You can think about in your jurisdiction, the contacts that you have that you can reach out for yourself and also for your patients or your friends, your sister. All right. Men violence against women is nothing to be proud of. Remember, we also said that not all of our pregnant women, their partners are males, so we need to take that into consideration. There is no excuse for abuse. 1 in 3 is a call for action. It is a societal problem. It is massive. It is a crisis. You know, let us as sisters, midwives, whosoever, that we reach out and try to save ourselves. I remember I'm a gender person, so I'm going to include myself, ourselves, our families, our mothers, our whosoever. Save our boys, save our women and the next generation. All right, thank you for putting gender-based violence on the agenda. Thank you. I will stop sharing.
Thank you. Thank you so much, Dr. Peter, for that presentation.
You're welcome.
And it's a lot for us to think about. I am sure we'll have many questions at the question and answer session. Sergeant Harris, are you prepared for us now, sir?
Yes, I am.
Just
Okay.
go ahead for us, sir. Thank you so much.
So I will hand over my presentation to my colleague, Woman Corporal Tanisha Atherton. She will go through the presentation with you guys for me. All right, just please allow me to share my screen.
Yes, go ahead.
Video isn't on. It won't be showing anything.
Okay. We are seeing the screen.
Okay, okay.
Good evening, everyone.
Good evening.
I must say thank you for having me. Filling in for Sergeant Aris as he is feeling ill. All right, so a lot of the information here based on some of the presentations that would have gone on before me is duplicated. So I won't reiterate what was said before. I'm sure by now we would have gotten the definition of domestic violence or gender-based violence. So I'm just gonna move on from here. So understanding domestic violence, it is widespread and it affects persons from all levels of society. It doesn't matter what strata you're from, it is there. The most pervasive form, though, is the intimate partner violence. And when we talk about intimate partner, we speak of your spouse or boyfriend, girlfriend, as persons would say. So this intimate partner violence, it is a issue that is occurring at with individuals, family, within the community. It affects the way in which we interact with each other. And we want to work on the way the risk is presented in terms of reduction. Domestic violence can never be an excuse under no circumstances. And the root cause are gender imbalance and the use of power and control. There are the different types of abuse or domestic violence, domestic abuse, as we may call it. And that is a psychological abuse. We're just gonna give a brief run through abuse, so this affects the way the individuals think, right? It makes you feel useless or worthless or kind of like you're going insane. Then there is the verbal abuse, where persons
tend to defame the other, you know, and in terms of how they communicate with you to put you down in such a way that, you know, it really is demeaning or a condescending kind of way, and make you feel too as if you're worthless. And this can come in the form of threats and escalate further to the physical abuse, which we're going to share on later. And then we have also the sexual abuse. And this is when you're forced into sexual activities, you know, against your will. And the physical abuse, which is it is more visible. This is where, you know, persons have to seek medical attention at healthcare facilities. And so it is the poking, the biting, the burning, slapping, the ear pulling, strangulation, weapons are used, smashing of things, hurting children, pets, you name it. The cycle of abuse, and we break it down: love, hope, and fear. Domestic violence, it often presents itself as a repeated behavior, hence the cyclic term there. And in the context of the relationship, that may prevent the victim from leaving. Not every abusive relationship follows this pattern, but many victims describe their relationships in this way. So first we have the honeymoon stage. And of course, you know, this is the nice part. You know, you get the butterflies and all of those things. You can't get enough of each other. And sometimes when they're so close, not even breeze can pass through. We've been there, right? Yes, so hence the word, the honeymoon phase. And then from there we have the tension building phase. And it's like you can't really do anything right for this person anymore. All of a sudden, you know, you feel as if you're walking on eggshells, so to speak. So from there, you know, it's like, so even if when you used to go on 2 dates per week, all of a sudden now the date thing just reduce, and the name calling starts, the tensions are rising, and from there it tends to escalate to the abusive incident, right? So now you feel like you must squeeze your hand or wring some part of your body, and you know, the beating and normally ensues. And you know, that's when persons tend to want to resort to the police, because they realize now that, you know, it's not anything that can be overlooked anymore, because the neighbors are hearing what is happening. It's drawing public attention. So persons now want to really know what else can be done, what is the result to this. And so often from there now they come to the police or some other partner, because we have several persons that we partner with, whether it be the Bureau of Gender Affairs or the victims, the Women's Incorporation Unit, and other agencies as well. So persons reach out to the domestic violence centers as well, you know, just to get help to see what can be done in these situations. And as I was explaining before, when it escalates to even before because of course it can be psychological as well, and it is going to play on your emotion, right? So persons are going to feel limited in the way that they function because there is just so much going on at home that is preying on them. So healthcare and fatalities domestic violence can result in headaches, pain, limited mobility, overall poor health. Fatal outcomes are homicide, suicide, and of course, even today, an incident in St. Anne where the female was allegedly killed by her spouse and he attempted to commit suicide. I'm not sure how many of us would have seen that video in circulation, but we are not here to condemn anyone. We just want to ensure that persons get the help that they need to really alleviate these situations, you know? We have the reproductive issues. So more often than not, women in these situations, they tend to have unintended pregnancies, or what we call unwanted pregnancies, induced abortions. So they don't want to carry the child, you know, because of sometimes they're afraid that the child might even resemble the man or the person that abused them. So they don't want to have the child because they don't want to be remembered they don't want to remember the situations that brought about the child. And of course, we have the sexually transmitted infections and more likelihood of miscarriages, stillbirth, preterm delivery, all of those things. We have the mental anguish, as I was explaining, the psychological effect, and this can lead to post-traumatic stress, depression, anxiety, and other varying disorders. And of course, when children are involved, they tend to grow up, you know, with these kind of violent traits too, because how many of us really understand that children live what they learn? It's more, they more grasp to what they see other than what we even tell them. They are very good observers, and sometimes we kind of underestimate how smart our kids are. I have a 10-year-old and a 16-year-old, and I can tell you, man, the questions that they come with sometimes, listen, they really test you, you know? So they really pay attention to what is going on as opposed to what you're telling them. And that is why we ought to portray the kind of attitudes that we want for them to grasp. Because if it's the good thing that we're showing them, then that's what they're going to grasp. And similarly with the bad things, you know, such as these violent situations. How can you sway their minds really when this is what they are witnessing in the home, you know? So we have to really be mindful of the effects that it has on them. And of course, when cases like these come to our attention and children are involved, we make referrals to the Child Protection and Family Services Agency, and of course, they conduct investigations into matters of this nature. The socio-economic factor, still on the impact of domestic violence, so this really cause a kind of debilitating effect on the women's ability to work, and to earn an income, you know, and it really drains on their participation in regular activities. So probably they would even have their extracurricular activities that they would engage in, you know, whether it be to play netball or whatever it is, maybe active in the community, you know, in community groups and so forth. And all of a sudden, no, they are withdrawn, no longer have the zeal to participate and get involved. You can see them at work too, you know, they are just there, but you can see that they are not present, you know. So those things can really have that kind of negative effect on their ability to earn and to really be productive. How the JCF respond? So we have seen how devastating these effects of domestic abuse is on families. And of course, you know, families, they form the community, and then within the community, we have, from the community, we have a country. You know, in 2008, the first domestic violence center was established at the Constant Spring police station. And this was with the aid of the US Embassy and in collaboration with the United Nations Development Program. They have the Spotlight Initiative. 10 more domestic violence centers were formed and are now in operation across the island. These contacts will be provided later on in the presentation. Someone might. Right, so your contact with the center will be at a moment of heightened distress. So to effectively assist you, you must be prepared to provide the police with accurate information and willing to work with trained counselor who is assigned to assist you, right? So I know in situations like these, more often than not, there is that fear factor in coming to the police. We implore and persist, and of course, we try to make them feel as comfortable as possible. Don't wear uniform, as you can see, just like how Sergeant Aris and I are attired. This is how the center managers are attired. So it has to get persons to feel much more comfortable and just to know that, yes, it doesn't feel strange just coming to the police, because it's like, you know, me and you and me kind of thing. So yeah, we take that into consideration, you know, and we try to be as confidential as possible and as sensitive about the situation, so persons don't shy away from coming to the center. Here are the list of domestic violence centers. You can take a screenshot if you may. I'm not certain if this presentation will be provided, but that's the information, contact information for the 10 centers across the island. How do we detect the signs when somebody is abusive, they seem afraid of their partner, are always anxious to please him. And what do we mean by that? The victim, and I heard Ms. Peter quite clearly and explicitly explained the difference between the victim and the survivor. So I know we have an appreciation for that. When we see women to the center, or because in this case, of course, we are talking about the violence against women because that is a real cause for concern. We have mostly women coming to the center, and there is a study too done last year that 1 in every 4 women are abused by a male partner, and that accounts for 25.2%, and 7.7% of them are sexually abused. So we have males coming now, but not in the quantity compared to the female. So they seem afraid of their partner and always anxious to please him. You know, you just want to just do everything right. They tend to want to just do everything right because they don't want to do anything that they think might upset him, right? So nothing is wrong with you wanting to please your partner, but of course there is a distinction, right, between the two. You wanting to please him as opposed to you feeling like you're afraid of him, so you do these things out of fear and not just because you just show love and compassion, you know. So it is a fear part that drives what you do. They have stopped seeing family members, so more often than not, you know, there is a disconnect between the family and the victim. Their partner uses and often criticizes and humiliates them in front of other persons, make you feel small. And that really, in essence, it makes them feel like them have the power over you. Them can do that. So when you feel small now, then your self-esteem depreciates, and you won't have that, you won't feel empowered to move out of the situation, you know, because your self-worth is decreasing or have diminished. They say their partner pressure or forces them to do sexual acts. So whatever sexual acts that is forced, or they've done it against their will, those are signs. Their partner often orders them about or make all the decisions. So you cannot make decisions on your own. You often feel as if, you know, if I know him, it's like you can't think for yourself. You cannot, you're not wise enough to make decisions. You know, you're ordered around and feel like that there is no sense of stability when it comes to decision makings. They often talk about their partner jealousy or bad temper or possessiveness, right? So it's like, in a sense, they are defending them, because anything outside of that would feel as if they are going against the person, or they are doing something wrong. Their children seem afraid of their partner, have behavioral problems, or they are withdrawn or anxious. And this, more often than not, they act out at school, you know, they can't focus. The grades start to go down. If they were a child that normally produces good grades, the grades start to fall, and their attention span is much less, you know. Sometimes them look as if their days in just in a space, as how we put it, that kind of way. So we have to pay attention to these things, because all of these are red flags. And if we are not very observant, then we will miss it. And of course, we do our school visits and we work also in partnership with our schools. We have our school resource officers, and they go in and provide us with information and what is happening in the school community. And at times we too ourselves, we go in and have that one-to-one with the principal, the dean of discipline, and so on. Continuing on recognizing the signs, they are reluctant to leave their children with their partner, more because of fear of what they might do. Most of these partners that are abusive, they are also abusive to their children. So we have to be mindful of these signs. And I know Ms. Peter would have shared on these things as well, in terms of, you know, the victims going there, and so more often when they make inquiries, they realize too that the children are being abused. The partner constantly keeps calling and wanting to know where you are. So this constant checking up, you have to know, they have to know where you are, as nothing is wrong with your partner making inquiries on your whereabouts, but if they constantly need to know where you are every single minute of the day or on the hour, you know, and you feel like you are in some way overwhelmed, if it feels off in that kind of way, then it is wrong. You know, they have physical injuries or bruises, broken bones, sprains, etc., and may give unlikely explanation for their injuries. All of these are red flags. I have dealt with so many of these incidents, and persons present that they sometimes they give stories other than what is the truth of the matter, because they fear these persons. And sometimes it's even persons who have, you know, these high status in society, and they talk about who they're connected to and those kind of things. So they, with that fear factor, they really don't want to say much, you know, so they try to be as secretive about the matter as possible, so as to not for the police have enough to investigate to have this person apprehended. So they give you a story. You know, I can even recall because I too am a survivor of domestic violence. There was an earlier on in my younger years, my first boyfriend, he was very abusive, and I remember one night I was leaving for home, having come from work, and we were on our way home, and I don't remember what upset him, but he had this ring on, this ring, and he just flung his hand back and it went straight in my mouth, and my mouth was bleeding profusely. And when I went home, because at the time I was residing with my grandmother, and when I got home, she was asking what's wrong with me, and I told her that it was an accident. I shied away from telling her the truth about the matter because I didn't want her to have that tainted image of him, you know, so I just tried to hide it as much as possible. And even when I went to the dentist, I think it was probably 3 days after, because I was in excruciating pain. And the dentist asked if I was in an accident because of the damage that it caused. And I didn't tell her the truth. I did the plastic surgery and they just remedied the tooth. And I just told everybody else a story. So these things happen, you know? What do we do? Speak with the person, approaching them in a safe manner, because we want to ensure that they are in a space where they feel as if they can speak to you in private. What they're saying to you will remain confidential. So we don't have them in the guard room, in the open, that reception area where it's in the open, where other visitors to the station would come in. We have an interview room, or we send them to the domestic violence center. Never blame or suggest that they provoke their partner. And this is very important because sometimes we're tempted. We can be tempted to suggest that, oh, I must you do something. I must you do something to provoke him. Why would he do that to you? I must you do something. And that will even cause the victim to blame herself or himself, you know, thinking that they have done something wrong. Let them know the abuse is not their fault, right? If concerned for their immediate safety, contact the police. If they decide to press charges against the abusive partner, your statement can help them document what they have experienced. Action plan for the domestic, for victims of gender-based violence. So what we endeavor to do is to ensure that persons get the appropriate assistance, and we utilize proper referral channels as well, right? We have our partner agencies such as the healthcare sector, Victim Services Division, Bureau of Gender Affairs, the courts, among others. And with this, we have a definitive action plan between all agencies that will all be better to assist each victim of domestic violence. And we understand that it is not a one-size-fits-all approach. We assess every situation on its own merit and try to formulate the right action plan for each case. And we have come to the end of our presentation. If there are any questions, feel free to throw them out.
Thank you so much. And now it's the time for the questions. Now, allow me to introduce Ms. Bernadette Regis from our Education Committee, who will take over the question and answer session. Bernadette?
Hi, good night, everyone. Thank you, Desiree. And
welcome, Bernadette.
And for those of you who do not know, I am Bernadette Felix Regis, and I am from the Caribbean country, St. Lucia. And if I may add, the only Caribbean country with a drive-in volcano. So welcome to this much anticipated, most exciting part of the webinar, which is the answer and question segment. Well, this is your opportunity to engage directly with our presenters, our experts, and dive a little deeper into the insights and knowledge that was shared during the presentation. So whether you have a burning question, you want to see clarification, or simply wish to explore the topic a little further, we encourage you to participate actively. So this is there is no such thing as a stupid question, and I am pretty sure that our presenters are eager to provide the information that you're seeking for. So let the question and section let the question and answer segment begin. So if I may, I think from the chat, we had quite a bit of expressions of appreciation. Persons were very grateful for the topic, very interesting topic. There was a lot of comments, and I think we have some hands up. Just before we go into the questions I could pose in the chat, let me just recognize the hand of Kamara. Kamara, you can turn on your mic and ask your question.
Good night, all. I am a midwife in Jamaica, working in St. Catherine. And recently, a pregnant woman came. Well, this is the second time I'm seeing her. But on this second visit, she revealed that she's been, I saw scars on her hand while examining her. And she revealed that she was being beaten by her baby father. She has a 2-year-old along with her on the visit. When I asked, what happened when the fight occurred, she said it was public in the community, everybody saw. And she said she went to the station, she called the police. And they told her that they can't do anything for her. And I think they directed her to call the Center for Women for Violence Center. And she showed me the phone with the number on it that she spoke with the person. And they told her that they can't help her either because she's pregnant, and what would she do with the child, because they can't take her in with the child. So they asked her if she have relatives and so on. And she said, no, she's not from this parish. So all her family should have anybody to go to really. So she's just left there still at that house. So in regards to what the corporal female presented, I'm wondering now how would that work, because it seems as if the systems are there, but when it comes to certain unique parts of it, this lady's pregnant, she actually have other children, it can't work. So I think maybe some other system might need to be in place for that specific type of thing, where you have children, you don't have nobody else, what do you do? Because she gone back home to this man, That's my question.
Mr. Byrne, just to address what you would have said, I know that on the behalf of the police, we have a lot of sensitization to do more around domestic violence and the referral channels. I know this case might sound unique to you, but I know that I've dealt with cases like these before. We have assisted pregnant mothers along with child to put them in shelter, because BGA, Bureau of Gender Affairs, they have a woman shelter that deal with these specifically. So once the matter is reported to the police or it is brought to our attention, we first make contact with them to have these victims sheltered. So I'm not quite sure. Can you tell me where you say the incident took place again? Which hospital you work at?
Oh, I work in the community in Spanish Town, the St. Jacob Park Health Center.
Okay. I know that there is a domestic violence center in St. Catherine North Division. However, there is one in Portmore. So might this situation arise again, what you can do is also refer them to the 100-man police station, because there's a domestic violence center there, and I know they will get the necessary assistance that they need.
Okay, sir.
Okay, thank you, Kumaro, for your thoughts, your comments, and your question. You can lower your hand now. Let us go over to, I see Caroline Peter Walker. Do you have a question? You can turn on your mic and ask your question.
Good evening. I'm also from Jamaica, and Mr. Corporal, sir, we have 14 parishes, and I think I count 10 centers, but they are in about 8 parishes. So like for me, that is linked with St. James and Hanover. Let's say we have a case, because I work in the primary care as well. What do we do? Do we go to the nearest one to us? Because all the parishes don't have the centers.
Okay, all right. So I know that not all the parishes are centers, all right. However, the Community Safety and Security Branch, at each division, there are trained persons to deal with domestic violence at these centers. And also the nearest center to you would be the one in Negril. I know that it's a bit far-fetched. Should the person need the requisite assistance, they can also make contact with the center in Negril also.
Thank you.
Sergeant, I think it's a work in progress. I believe the centers are at the point where, out of the UN study, where the most domestic violence are reported. That's where the priorities are now. But like you said, persons would have to use the nearest division and be aware of the Bureau of Gender Affairs. They have 2 centers, I think not centers, shelters. And I think they're looking at having more.
Right, so Dr. Peter.
Okay, thank you, Caroline, and thank you, Dr. Peter, for your insights. I think we had a question earlier in the chat. I think it was more directed to Dr. Monique Lynch. And the question was, within the last 5 years or so, there has been an increased sensitization among, within the last 5 years, there has been increased sensitization awareness related to gender-based violence. Has there been any improvement in terms of a decline in the incidence of GBV, especially in the Caribbean? Dr. Lynch, would you want to take this question? Although I know you indicated you will give some stats in terms of 1 in 3 women being exposed to gender-based violence. Would you want to give some more insight into whether we have seen a decrease or improvement in gender-based violence within the Caribbean?
Just to help Dr. Monique, I know from a Jamaican perspective, based on our last women's health survey that was done in 2016 and was made public in 2018, it shows that there is a decrease coming from the 2008 women's health survey that was done. During that time, it shows 2008 was 35.4 women who have ever been in an intimate partner relationship reported that they have experiencing intimate partner violence. And then in 2016, it shows 1 in 4. So that shows that there is a decrease. But we can't just say there is a decrease. We can't just look at the numbers. Is it decreasing? Is it increasing? As long as there is one person at risk, we have to intervene. It's just like HIV. We thought HIV would have been gone. And we have to keep doing, educating and promoting, etc., etc. And that is why we are here. So that's a very good question. Gender-based violence, sometimes it can be tiresome and you think you're not reaching anywhere. Just plant the seed. Like when you're spreading the gospel, just plant the seed, and hopefully one day that woman will have the opportunity to walk away, or that spouse will have the opportunity to look into his or herself and stop abusing someone.
Okay, thank you, Dr. Peters. Well, I don't see any hands up currently, but we will go into the questions that were posed in the chat earlier on. Somebody asked, how do you balance gender-based violence and support the family, especially during pregnancy? How do you balance gender-based violence and support of the family, especially during pregnancy?
As midwives, we give individual care. And if you look back at the psychological first aid, that you look, you listen, and you link. You can't do it by yourself, you know. It's to eradicate or to reduce gender-based violence. It has to be a community. So it's not one midwife in her space. You have to use the resources that are around you and use link, use the psychological first aid. What is it that you're seeing? Listen to the woman, because it's about empowering. It's not you making decision for her. It's you giving her the information for her to make a decision. So continue to be giving her care once you get the opportunity. Probably you are the first person ever would have shown her love. If you look at her, instead of saying Kamara Hepburn, you said Miss Hepburn. Probably as if you're the first person who call her Miss. All right, so you just do your path, wheresoever you are, and use the resources, the referrals that are available. And that is why I'm saying to us, look at our institution. What can we do? Who can we use? How can we use our power of influence in our community, in our health center, to make a difference?
Okay, thank you, Dr. Peter. I think there was another question. I think that question would be directed to Sergeant Harris. Is there any measures of state protection for midwives who have to be a witness in a case of IPV? Is there any measures of state protection for midwives as nurses who have to be a witness in a case of IPV?
While Sergeant coming, I believe the midwives working institution should be protected by the institution. This is why we need screening protocol that will answer these questions. Who should go to the court? Is it the midwife, the social worker, the medical doctor? So we need protocol to guide us. And get support from the institution.
Okay, most certainly, I quite agree, Dr. Peter, with that response.
Okay, to address the first part of the question, as it relates to if it's a case where the midwife has to go to court.
Has to present herself in court, yeah.
Yeah, if it is one that the case is of a serious nature where the midwife is a witness, and there is a feeling that there might be threats surrounding the matter, we have a witness protection program that we normally put our witnesses into. The other part of it, as it relates to who should attend court, in some cases, we deal with witnesses that might witness an offense on view. So in that case, the witness, either the doctor, the midwife, or the nurse, once they view it, they would be the person who has to attend court. If it is a case where a medical is granted and it is needed for the court purposes, normally the medical doctor is the one who issues that, and they don't have to be present in court. So the only time that we really required any of the three healthcare workers to be in court is most likely when an offense is committed or witness on view of any of the three.
Okay, thank you, Sergeant Harris. I'm trying to navigate through the chat to get our question, but I don't see any hands up as yet again. I do have one question for Sergeant Harris, though, if I may. Sergeant, what protocols or procedures does law enforcement follow when responding to gender-based violence in your country?
Okay, all right. So we are guided by what is known as the domestic intervention policy. So once we got a call to respond to an assignment, the responding officer, first they would have to deal with if the person required medical attention. So if that is the case, they will have to take the person to a medical facility to receive medical treatment. If it's not the case with a physical violence, say for instance, it's one of a verbal nature or involved threat, they would have to take that party to the station where a report is given. These matters are treated in confidentiality if it is one of gender-based or domestic issues. Once the report is appreciated, we deal with what is known as a referral pathway, where we have referral form or risk assessment form done. And the matter is then referred to, that is where the domestic violence intervention centers come in. Once it is referred to the domestic violence centers, we do the necessary that is related to seek counseling for the victim. We also, it is a case where the victim has to leave the home in particular, we also correlate relation with gender-based violence, woman Inc. centers, just to get shelter for those persons. If it's criminal, the procedure is as in any regular criminal matter where it is referred through the courts. Another part of the action of the court also is that we get protection order for the victims against the perpetrators.
Okay, thank you. Thank you very much for your response. Much appreciated. I noticed we have one. The individual said, "Good evening, everyone. In a situation, you know, a client is physically abused based on signs, but she refuses to talk about it. You advise and encourage her to talk about it. What else can be done for her?" Anybody want to take on that? Dr. Peter, Dr. Lynch? In a situation, you know, a client is physically abused based on signs, but she refuses to talk about it. You advise and encourage her to talk about it. What else can be done for her?
I think if you look at link, the psychological first aid, if the person is not ready, if a patient, you're giving the patient the painkiller, the patient doesn't want it, what else can you do? So if the patient is not ready, you cannot force the person. You document, you make notes, you reassure her, you give her a pamphlet, you link her with all the various things. That's all you have to do. And if you, what is the mechanism? What's the pathway at your institution? Do you refer to the social worker, etc., etc.? But what you're to do is to give her information. And when she's ready, she will act on it.
Okay, thank you, Dr. Peter. Just a follow-up question to Sergeant Harris. What advice would you give a nurse who comes in contact with a client who refuses to involve law enforcement? Is there any advice you would want to give a nurse in that regard? Have we lost some sergeants?
Just repeat the question, please, ma'am.
What advice do you have for a nurse who comes in contact with a client, a case of gender-based violence, and who is hesitant or fearful of involving law enforcement? So the person doesn't want to involve the law, but there is a need for that. As a nurse caring for that patient or that client, what advice, from a police perspective, what advice would you give the nurse?
Well, there are other referral paths that can be explored. I think the primary focus here is to ensure that the victim gets the requisite assistance that is needed. So if there is a fear factor involved, I think more than anything that we are professionals, and I'm sure Dr. Peter would agree, right? So if it is that the victim is not against disclosing this information, right, then the proper procedure should be followed in ensuring that the full disclosure is made and the victim gets the requisite assistance that is needed.
Okay, thank you very much, Sergeant. I noticed we have one hand up, Christina Ramsey. You can turn on your mic and ask your question.
Hi, good night.
Good night.
Can you hear me?
Yes, we can.
Okay, just want to first say very informative, well needed presentation tonight. From my little experience, I've come in contact with women who have, been abused and all of that. I remember I had a pregnant young girl too. She was like 19 at the time and stuff. She was beaten by the baby father while she was pregnant and all of that. And when she went and made the report, he actually kicked her out of the house and so on. And then at the time, it was so challenging because trying to find linkages so that she can get the requisite help that she needed. Because she didn't have anywhere to go. Eventually, someone offered to, catch her somewhere and stuff like that. But, I would really like for there on the side of policy and interventions that we could have more safe houses across the island. I'm not sure what's the situation in the other Caribbean islands, because I'm from Jamaica, in terms of safe houses for women in these situations where they need to be physically removed from these situations that they are in so that they can get the help that they actually need. And I do realize their psychological well-being as well affects their seeking help and all of that. So, that will have to be a big part of reaching out to these women, is getting them the psychological help that they need. Because some may think it's okay. I remember one young miss postnatal, and, when I was talking to her and all of that, really her sexual activity, because, we're discussing family planning. And she was saying she had relations with her baby father, but it was not something she had consented to at the time. And so I was saying, how you feel about that? And it was like, Chuff, I something we do all the time. That was her response. And, someone in that situation really needs, and it's not like she can't do any better because she's a woman that is working and all of that. She has family that's close by enough and all of that. She doesn't have to be there, but she just think that, it's nothing. And that for me is that needs to be helped from the psychological point of that individual.
Okay, that was a comment, not a question. Thank you, Christina. But I see your point.
Yeah, I could comment on that because
Yeah.
we have to look at socialization.
Yes.
We are talking about men and women. So we are allowing the hurt and all of those things that are happening in the home with children, and these children grow up to be men and women. So that probably that young lady, that's what she knows. And we have to look at how we socialize. We have to look at how we talk around our children, because probably she think it's okay. Because Sergeant spoke about the honeymoon phase. A lot of women like that phase, because that's where you get things. Valentine's coming up, they're looking forward to the chocolate and all of that. And so it becomes the norm. They start to accept it. And the children in the home see these things when daddy and mommy fight. Then tomorrow, daddy buys nice things for mommy, and they think that's the norm. And they live like that and they grow up like that. So how are we, most of us here are women, how are we growing up our boys and our girls for them to become men and women? So we have to look at our socialization. And as midwives, we are the ones from day one can make a difference in breaking the intergenerational violence that is occurring. The things that we say, how we say to our young boys, let them feel entitled that they are king. Why you handsome me? Why every woman go run your dog? What are you telling that boy? You're going to be in Jamaica, we say Gallis, because mommy say me handsome, I'm supposed to have a heap of women. And although cheating and all of that is not included in the international literature, in my study, a lot of women say they feel abused when the men cheat. And our Caribbean men think that they must be gallis because we start saying these things. You're handsome and girls go run you down. And we say it all the time. We're watching television with our children and we hear of a case. And the first thing we start to blame the victim. Why should it go there? You know what that is saying to a young lady listening to you? She's thinking that when my time comes, if this happened to me, that's what people are going to say about me. So we have to look at our attitude, what are we saying, how we are growing up our children. We have to look at parenting.
Okay, thank you, Christina, and thank you, Dr. Peters. And for just to indicate for those persons who are asking about CME hours and whether it will be awarded or it will be given to them, the link for the certificate of attendance was posted in the chat. All you need to do is to click on the link and complete the questions that are posed on the link. So for those persons who want certificate of attendance or CME hours, please click on the link and complete the questions. I don't think I see, let me see any more questions for our presenters. Somebody just said practically every day there is a video of violence among children in schools. I know there are measures to stream this. What I would like to know though, any interventions for the children in early childhood institutions while the children are young and their minds pliable.
That's a topic for another day. That is a topic for another day.
I do agree
Talking
with
about the
that,
violence
Dr.
in the
Curtis.
schools, that is a whole different can of worms.
Yes, certainly.
Yes.
Somebody said we need to respect patients' rights. Very well. And if she is not ready, I believe we then need to adhere to our code of ethics. What does the healthcare worker do if they witness, what does the healthcare worker do if they witness the abuse? Do they have a responsibility to report this matter as an advocate for the patient, for the client?
Sarge, what would they do? I think
What would you recommend? as a healthcare worker who witness an abuse? What responsibility does that healthcare worker have? Do they report the matter, Sergeant Harris?
I know you have to talk with the patient because very often the patients don't want to report it.
Yes.
Yeah, and that has been said.
They're not ready as yet.
Yeah.
So we have to, as Ms. Peter correctly said, we have to take what the patient wants into consideration, right? And of course, there is a patient and doctor confidentiality. So if the patient doesn't want to disclose it, then the midwife or the doctor can't force the patient. We basically have to honor what the client wants. So it is on that basis that we treat with them, as much as we would probably want to do more. But what we can also just advise them, arm them with all the information that we have so that they can make an informed decision, continue to encourage, and to just point them in the right direction.
Yep.
Okay, thank you very much. Moving right along. One person said it's not a question, but a suggestion to her fellow colleagues. Pay a lot of attention to women empowerment sessions because a lot of the times women fail to report this abuse is because they are too dependent on a man. Okay.
There is no excuse for abuse.
Yes. From Antigua, this is my little input in Antigua, and I still believe most other countries in our region have the same challenge, certainly. Okay, I don't think there are no hands are up. One person said this is a major challenge in accessing temporary accommodations during the time or period of abuse. Okay, another person said they have to report the issue and help the victims through the appropriate protocol as per their country. Very well. Okay, I think that's about it for our question and answer segment. One person, the last comment was that—
Thank you so much, Bernadette.
Yeah, just one last comment. One person said, but we are told that if a child is being abused, we should report it. Well, the child is a minor, yes, we should. In a case like, I would agree that in a case like that, the child is a minor and cannot make a decision for him or herself, so definitely. So I think that's about it. Over to you, Madam Moderator.
Thank you so much, Bernadette. I'll now hand over to Marcia Rollock. Marcia?
Hi, good night, everyone. The evaluation link is in the chat for those who wish to do the form. The link is in the chat. I would just like to thank all the persons who presented for us this afternoon. Tonight, recognize it was so interesting, all the topics and all the presentations that we have gone way over time. But we want to thank all the presenters for their insightful presentations. Dr. Monique Lynch for her comprehensive presentation on the causes and management and the strategies for gender-based violence. For Dr. Cynthia Pitter for her insightful presentation on our role as midwives in the whole gender-based violence issue. Also like to thank Sergeant Karen Harris and his assistant, woman constable, woman corporal, who did the presentation. And we want to thank her for bringing forward the signs and symptoms and sharing with us the domestic violence centers. And also we want to thank her for sharing her personal experience with us on this forum. We can tell, you know, how passionate you are about what you do. We want to thank you all for being part of this webinar. We would also like to thank Deborah Stewart, our able moderator, who kept us all in queues and kept the program running smoothly. We want to thank Ms. Bernadette Regis for conducting the Q&A, and the topic itself lends itself to so many questions. And I mean, we could go on and on this topic. So I want to thank you, Bernadette, for being able to pull the questions from the chat and for inviting persons to ask the questions on this forum. I would also like to thank all of you who attended, all 500 plus of you who attended this webinar. It shows that this is a topic that is really interesting to lots of persons. It is a topic that is widespread across the Caribbean. And it is a topic that persons want information on, particularly as midwives, because we encounter these clients all the time. So I want to thank everyone for attending this forum. And we ask you to keep in contact with CRMA to see further webinars as they come along. As we have them, we'll advertise them. So I want to thank you all for being part of this webinar. Shirley, do you have any parting words?
No, just thank you very much to our present. This was a good start off for the year. And we hope to maintain the same momentum as we move forward in our webinars. We try to keep them monthly, but at least every other month. But we'll try to keep them monthly. We had, as Marcia said, about 500 persons on the site tonight, and we had 15 countries represented. Now, if you did not put your country in the chat, you can do so at this time. But we have Guyana, Belize, Jamaica, St. Lucia, St. Kitts and Nevis, Trinidad and Tobago. We had Antigua and Barbuda. We had BVI, British Virgin Islands, Montserrat, Turks and Caicos, Dominica, the Bahamas, Cayman Islands, St. Vincent and the Grenadines, and Grenada. And we also had somebody from Tampa, Florida. So we thank all of you. Thank you, Ms. Swan. You can mute your mic.
We also had somebody from Suriname on the call.
Okay, we missed Suriname, so 16.
Yeah, 16.
Wow. So a great start, everyone. And awesome. So you take this time now to complete your
evaluation.
If you want to have a certificate, you must complete the evaluation. All right, must complete the evaluation.